We shall go on to our next speaker, Dr. Vivek Warkad, who is a senior consultant neuro-ophthalmologist from L.V. Prasad Institute based at Bhubaneswar, and he's going to be talking on another interesting topic, intelligent diplopia management in cranial nerve palsies. On to you, Dr. Vivek.
Can you see my presentation?
Yes. Yes.
Yeah, so thank you so much for this great opportunity. So basically, I'm going to talk about intelligent diplopia management. I think I have to make the diplopia management, more intelligent. And luckily, I do tackle these patients, when they end up with having, the strabismus. So basically, history is most important. What is the onset and progression? As we all know, during our fellowship and residency, we have been taught always look for, the other examination finding like variability with head posture. Is the previously, there was a similar kind of episode, especially if it is associated with other neurological symptoms. Is there any, the associated spontaneous resolution? And the most important thing is what is the associated history? So is it associated with trauma, neurological signs and symptoms, or any past medical history? So having said that, like if you actually start to evaluate, these patients with double vision, does covering either eye make the diplopia disappear? So that you need to actually, rule out the monocular diplopia. Is the second eye or the second object is being displaced horizontally or vertically or obliquely? If you start to answer these questions, probably, you would end up with getting, what kind of the diplopia and what is the basic cause of this particular diplopia is going to get. So if you see this simple example, like 56-year-old gentleman who is complaining of double vision, which is sudden onset for 4 days. So you ask this question, does covering either eye make the diplopia disappear? Yes. So is the second object being displaced horizontally or vertically? So if it is horizontally separated, then is it in the same in all the direction of gaze, or it is worse in the right gaze? Suppose the patient says worse in the right gaze, then probably, like we are dealing with something related to the abduction or, the sixth nerve palsy. So that is how it is very important to understand that, the binocular diplopia is secondary to a neuropathy, myopathy, or neuromuscular junction disorders like, the ocular myasthenia. So ocular alignment evaluated in a primary gaze, up gaze, down gaze, like in a different gauges, including for distance and near. That's how we do actually in a clinic, by doing cover test. So look for any additional signs like how's the ptosis, pupillary abnormalities, innervations, lid fissure changes, and associated ptosis. So if you come across a patient, with double vision, with ptosis and anisocoria, then probably you need to think about like eyes test or, ordering for neostigmine test, where you would actually pick this up as a primarily ocular myasthenia and not the cranial nerve palsies. I think this is one of the close differential diagnosis, or OMG can mimic, any one of the cranial nerve palsy that we come across in our day-to-day clinic. So regarding the vertical diplopia, always perform a Park step test. I'm not going to go into the detail, but as we understand that, like if there is a right hypertropia, then there would be, the less hypertropia on the left tilt and more hypertropia on the opposite gaze. That's how we pick up either of, the 4 possible involvement causing, muscles involved to cause that particular hypertropia or other eye hypertropia. So these are the tools that we use in our day-to-day practice in a clinic. Most important examination is a fundus examination, where we need to look at the disc properly to rule out, the papilloedema. So that is sometimes could be, the pulse localizing sign, which is suggestive of sixth nerve involvement. But what is the approach? So complete ophthalmic evaluation, relevant neurological evaluation, particularly, the cranial nerves. Neuroimaging is important, the integral part of evaluation of these patients. Ancillary tests like eyes test, neostigmine test, diplopia charting as and when required, and the appropriate referral if you are a comprehensive ophthalmologist. What is the management approach? So we have a non-surgical and surgical options. So the conservative way is one of the best, or the intelligent way of managing the double vision in cranial nerve palsy. Wait and watch for spontaneous recovery. Monoocular occlusion. If it is a fourth nerve, then you can use, the translucent Scotch tape occlusion for a reading segment of, that particular glass where, the patient would be more comfortable in down gaze, and treatment of the associated ischemic risk factors for all cranial nerves. Glasses and orthoptics, they would add a great value, taking like undercorrection or overcorrection depending upon, the fusional versions of the patients. Orthoptics, yes, you can use, the different methods to improve the convergence or divergent capacity depending upon what type of strabismus after, resolution or in the evolving stage of the cranial nerve palsy. Orthoptics, when we have the exercise like cat's card or, the Brookstein to build the versions and thereby to reduce the double vision. Prisms, there are two options. Most of the time, if the deviations are smaller, then we can use slab of prisms. Otherwise, larger horizontal deviation, you can always tie, the Fresnel prism. And nowadays, there are Fresnel press prism, which has, the less thickness, and they do give, they become more thinner and more cosmetically better. Treatment examples for conservative non-surgical management, you can appreciate this female who presented with, the gross abduction limitation. So this was a 6th nerve palsy. However, the important reason for this was ischemic origin. You treat the cause of ischemia, and you would end up with amazing outcomes over a period of follow-up. This is another example. Believe me, complete pupillary non-involving third nerve palsy, if it is ischemic, you can get rid of, just wait and watch, treat the risk factors. So what are the stages of paralytic strabismus? You need to understand how the paralytic, the palsy of particular nerve that evolves, that we need to understand. Once we understand this, then probably, at different stage, you can utilize the different modalities of treatment. So if you look at the 6th nerve, we have these options, either recession, recess resection, or transposition procedure. So nowadays, over a period of decades, we have been knowing, practicing, we have our own experience of, tackling these patients when they come as a traumatic bilateral or unilateral 6th nerve palsy. You can always do, the bilateral medial rectus and a superior rectus transposition to LR that we call SRT. You can get an amazing outcome, and this patient will get rid of, the double vision. Third nerve, yes, again, depending upon at what stage of evolution of the third nerve, after being wait and watch for, 6 to 8 months when it comes because of, the traumatic nature. So then you do have a different option, like if there is aberrant regeneration operating into the normal eye, or, taking a call for transposition of supraoblique into the adduction, orbital periosteal fixation when there is an extra tight lateral rectus where you can't split, the lateral rectus and transpose to the MR. So there are n number of, the indications for different plethora of, the surgical approach that we do have in our surgical tray. This is a very interesting case. You can see 26-year-old male came with traumatic left eye third nerve palsy with underlying TRON, and you can see how dreaded the adduction limitation. There was an aberrant regeneration, which is the inverse Duane sign. So I took a call, okay, let's, on table I found, the LR was super tight. So I decided to go ahead with the normal eye R&R. That is what, the Dr. Sharma sir and all, they have, like introduced this procedure to operate a normal eye, and you would get a, rid of the aberrant regeneration. As you can see, there is a remarkable improvement. Although there was a extra large XT, which has now become a large XT. However, the patient has a double vision for a vertical thing. So here there was a large hypertropia. So here I decided, okay, so I did an inferior rectus recession 2 millimeter, and then transposition of which I deferred the first surgery, lateral rectus, to transpose it to the superior rectus so that I could help the patient to get, rid of his very large left hypertropia. And you can appreciate how amazing, the hypertropia has been corrected over a period of time. So I think if you treat these patients in a systematic way, you can make actually miracle. You see the timeline of this patient over a period of 3 years. It's not about 1 or 2 visits. If you follow them on a long period, then you will find, those subtle changes that makes a huge difference in patient life. You see the adduction limitation at presentation and at last follow-up, and even the vertical deviation that helps them bring into, the fusional range, and then that's how we can take care of this patient. Fourth nerve palsy, yes, we do have different approach depending on how on table your traction test. if the the superior oblique is normal and at the same time inferior oblique is very tight, then you do have two approaches, to weaken the inferior oblique if the deviation is less than 15 prism diopter. If it is more, then you can do a two muscle surgery. Either you do a weakening along with superior oblique tuck. If it markedly lacks superior oblique, then you can do superior oblique tuck and other inferior oblique weakening procedure. This is an example straight ahead case, the right SO palsy, and that's how I went with doing along with XT. So I went with doing like bilateral lateral rectus and the IOH of right hand. You would get amazing outcome with no double vision. This I would like to give a technique message. The diplopia management in cranial nerve palsy can be intelligent given the systematic approach is taken to evaluate and find the cause. Smaller deviations pre or post-operatively can be taken care by orthoptic therapy. Strabismus surgery is recommended for larger deviations, and wait and watch is the best strategy in the initial phase of evolution of cranial nerve palsy. Thank you very much.
Thank you very much, Dr. Vivek. Wonderful talk. It was very thorough. Dr. Pradeep, I wanted to ask you one question. Do you feel there is a role of these mini plications and mini tenotomies in recurring cranial nerve palsy? Do they help at all?
Yeah, I think so. Those which are residual cases of small angle squints, mini plication is something which I have found useful. Mini tenotomies can be used as an adjunct that you want to have an additional effect at the time of surgery that you may do. As a mini tenotomy, as an individual procedure, I do not find much benefit. As described by Kenneth Wright, that the difference is only about 2 to 3 prism diopters after a mini tenotomy. So personally, I would say yes, mini plication can be an additional thing which can be done in residual cases when we have, especially if you're working on vertical muscles, inferior rectus. So that seems to be a very handy tool in addition.
Dr. Murli, can you take a question before we go on to our next speaker? Dr.
Yeah, I think Dr. Ambika had a question about, the Botox. So, there is a lot of debate about use of Botox. So I had left this practicing Botox in my practice almost 5 years back when I see, it's just kind of extra economical burden when we know that, the natural history of the disease is going to get, I was shown those 2 cases where it's a complete third nerve and, the sixth nerve. So if you wait and watch with the aggressive treatment of, the risk factors, you would get up with. Traumatic, yes, in early phase, people says, there is a kind of, the tightness of the recta and then, but it doesn't matter actually, it would alter just 1 or 2 millimeter of your on-table dosing of the recti muscles.
Thank you.
Yeah, Dr. Vivek, you mentioned the case of third nerve palsy with a super tight lateral rectus.
Yeah.
But lateral you only transpose to the superior rectus. So how did the adduction recover?
No, that I did the second procedure. So in the first procedure, I had that plan, but it was very tight. So I deferred doing, the Y splitting of LR to MR. So I decided, okay, anyway, the patient has aberrant regeneration. So I did a normal eye R&R. So I left that plan for the next step.
Basically,
so I did a three
but
times
FDT is positive. You are not supposed to transpose to MR, no?
No, over a period of time, that has become kind of better when I operated, maybe because of, the fixation duress that has been created by the other eye R&R surgery.
So mildly positive, Murli, you can use for nasal transposition still. And but other thing which you always need to remember that you need to do a post-operative FDT to ensure that the LR has been free. Many a times I do get cases which are done once, but they have failed because the LR has not been enough recessed. You may have to recess sometimes like 18 to 25 millimeters or even do an LR periosteal fixation. Make sure that the lateral rectus is totally annihilated for its overaction. Otherwise, none of the other procedures will work.
So on table, you may to make sure that, now there is no force on that side, lateral side. That means you are successful. You would anticipate next day there will be some, the positive effect. Otherwise, it is difficult.